Morning everyone. Today we'll be discussing about the medical management of glaucoma. Glaucoma care is more an art than science. Although the tools for detecting the glaucoma progression as well as monitoring the disease have been improved much faster in the last few decades, but still we are not able to predict prospectively which patient will do better or worse than the others. So there are various known risk factors for glaucoma, but the only modifiable risk factor still is the intraocular pressure. So all the anti-glaucoma medications, they work by either decreasing the aqueous humor production or increasing its outflow, thereby reducing the intraocular pressure. There are a list of anti-glaucoma medications that are now available, which includes prostaglandin analog, beta-adrenergic antagonist, alpha-2 adrenergic agonist, carbonic anhydrase inhibitors, cholinergic stimulators, and the osmotic agents. Like we can see, muscarinic agonist works on the trabecular outflow. It increases the trabecular outflow. Prostaglandin analogs works on the uveoscleral outflow, and the aqueous humor inflow or the aqueous humor production is controlled by the beta blockers, alpha-adrenergic receptor agonist, and carbonic anhydrase inhibitors. So coming on to the first class of drug, that is prostaglandin analog. It is the first choice drug nowadays because it is well tolerated, popular, as well as highly effective. The diurnal and the nocturnal IOP lowering effect of prostaglandin analog has been found to be the superior to all other anti-glaucoma medications available till date. It lowers IOP beyond 24 hours, so if once in a while patient miss the dose, it will get compensated. Although the mechanism of action is not fully known, but an increase in the uveoscleral outflow is considered as the primary mechanism of action. Some studies also suggest that prostaglandin analog increases trabecular outflow as well by regulating the matrix metalloproteinases and remodeling the extracellular matrix within the trabecular meshwork. But till date, enough evidence is not present to support this fact. Prostaglandin analogs are used in the OD dose with the nighttime administration. The peak effect comes after 10 to 14 hours of administration. The IOP lowering ability ranges between 23% to 33%, and it is highest for bimetoprost. Latanoprost and travoprost are the prodrugs that get activated after being hydrolyzed by the corneal esterases. Prostaglandin analogs are indicated in all forms of open-angle glaucoma, that includes primary open-angle glaucoma, pseudo-exfoliation glaucoma, pigmentary glaucomas, and the normal tension glaucoma. But these drugs are not effective in primary congenital glaucoma and angle closure glaucoma. Prostaglandin analogs are relatively contraindicated in patients with cystoid macular edema, inflammatory glaucoma, and herpetic keratitis due to theoretical worsening of the inflammation. Side effects of prostaglandin analogs are mainly ocular, that includes hyperemia, which is the most common, and increased iris pigmentation is observed in nearly 33% of the patient who are using prostaglandin analogs for 5 years or more. But increased iris pigmentation is seen in patients with hazel color irids. So other ocular side effects include periocular hyperpigmentation, hypertrichosis, as well as periorbitopathy. Although these ocular side effects were found to be reversible with drug discontinuation. We can see this patient is using prostaglandin analog in her eye, and we can see hypertrichosis and the loss of periorbital fat. So there are few issues that we need to consider when we start any patient on prostaglandin analog. If there is any active inflammation or a history of ocular inflammation, if there is a history of cystoid macular edema, or if dosing is to be prescribed for the one eye, will the patient be able to tolerate these potential asymmetric changes? All these factors we need to consider before starting the therapy. Now, second class of drug is the beta-adrenergic antagonist. These are also popular, effective, and generally well tolerated. These are also indicated in almost all forms of glaucoma. Non-selective beta blockers are timolol, levobunolol, and cartilol. They target both the beta-1 as well as beta-2 receptors, while as selective beta blocker, which is betaxolol, it specifically targets only beta-1 receptor. So mechanism of action so far known is it blocks the sympathetic nerve endings in the ciliary epithelium. It decreases the cyclic AMP production and subsequently decreases the aqueous humor secretion by 20 to 30% during the day. It is also found that the patients who are using systemic beta blockers, they get minimum effect of this topical therapy. So it lowers the effect in patient who are on systemic beta blockers. So IOP lowering effect is also decreased in night. So mostly beta blockers should be used in OD dose in the morning hour, or if it has to be prescribed on BD dosing, it must be with some combination therapy. It is also seen that if we prescribe beta blockers in the one eye, the other eye which is untreated will get some IOP lowering effect as well. This indicates that there is a degree of systemic uptake with topical beta blockers. We all know that beta 1 receptor has largely cardiac effects and beta 2 receptor has pulmonary effects. So betaxolol, which is basically a beta 1 selective receptor antagonist, has fewer respiratory side effects when compared to non-selective. But then because of this, betaxolol, which is a selective beta blocker, has a minimum IOP lowering effect. Cardiovascular risk is also seen because it is found that it decreases the high density lipoprotein as well as it increases the cholesterol levels. It can also cause bradycardia and bronchial disease, and we should use beta blockers in children with caution because they can reach high serum concentrations. They are mainly beta blockers causes systemic side effects which include bronchospasm, bradycardia, increased heart block, masking of hypoglycemic symptoms, decreased blood pressure, reduced exercise tolerance, depression, syncope, CNS depression. They are a battery of systemic side effects. When we look at the ocular side effects, they include allergy, punctate keratitis, corneal anesthesia, and aggravation of myasthenia gravis. Punctate epitheliopathy seen in patient using beta blockers. So what are the issues that we need to consider before starting beta blocker? If the patient have any respiratory or the heart disease, if the patient is at high risk for hypoglycemia because topical beta blocker may mask symptoms of hypoglycemia. If the patient have thyroid eye disease or the myasthenia gravis, then abrupt withdrawal can cause worsening of the condition. If the patient have problem with anxiety, depression, fatigue or impotence. Now coming on to the next class of drug, that is alpha adrenergic agonist. It causes decreased aqueous production as well as increased aqueous outflow. It is also indicated in most forms of glaucoma. Few studies have shown that they have neuroprotective effect which could provide an additional benefit in patients with normal tension glaucoma. These are basically short acting agents, so mostly used in pre and post operative setting after cataract surgery or after lasers. These are effective. Two drugs are available, apraclonidine as well as brimonidine. Apraclonidine is found to have more side effects, which includes follicular conjunctivitis and blepharodermatitis. However, low incidence of allergy is seen in patients using brimonidine. Still, long-term intolerance is found to be as high as more than 20% because of the local side effects associated with it. That includes hyperemia, blepharoconjunctivitis, ectropion and granulomatous anterior uveitis. If the patient is on multiple doses, multiple drugs, then we need, and if the patient present with the aforementioned signs and symptoms, then we need to suspect the brimonidine as the culprit. It lowers the IOP by 20 to 30% and may be used BID or TID depending on the fixed dose combination. If it is used with brinzolamide, then BID dosing. If torzolamide, then TID dosing is recommended. These drugs are absolutely contraindicated in patients under 3 to 4 years of age because this drug can cross blood-brain barrier and may result in fatal respiratory arrest, somnolence, hypotension, seizures, derangement of CNS neurotransmitters. It is also found that the drug is relatively contraindicated in patients who are taking monoamine oxidase inhibitors because it can mask hypertensive crisis. Ocular side effects, we normally use brimonidine. So side effects can be foreign body sensation, eyelid edema, dryness and ocular sensitivity. Systemic side effects may include hypotension, syncope, vasovagal attack, dry mouth, nose, headache, anxiety, depression and fatigue. We can see follicular injection in patient and severe hyperemia. Just we need to see if the patient is under 4 years of age, we are not supposed to start these drugs. Now coming on to carbonic anhydrase inhibitors, they act by directly antagonizing the ciliary epithelial carbonic anhydrase, which is an enzyme which is necessary for the production of aqueous humor. Systemic agents have a greater efficacy to reduce intraocular pressure by 30 to 50% as compared to topical therapy, which reduces the pressure by 15 to 20%. Systemic carbonic anhydrase have been used in medicine since many years, but their use in glaucoma is a bit restricted because of the potential side effect associated with it, and more beneficial topical therapy with less side effects is now available. Acetazolamide is considered more effective in controlling intraocular pressure than methazolamide, but it is then also associated with more side effects. Side effects of systemic carbonic anhydrase inhibitor is mainly dose dependent, which include paresthesias of the fingers and toes, fatigue, loss of energy, loss of appetite, abdominal discomfort and bitter taste. Patient may develop blood dyscrasias that includes aplastic anemia, thrombocytopenia and agranulocytosis. Hypokalemia is also seen in patients who are on diuretics. It is contraindicated in patients with poor endothelial dysfunction because it can cause corneal decompensation. There was a large retrospective study done by Lee et al. In 2004, and they use carbonic anhydrase inhibitor systemically in patients who were self-reported sulfur drug allergy without any adverse effect. So though it is a sulfur derivative drug, but can be used safely in patients with sulfur allergy. There are few issues that we need to consider before starting the therapy. For topical use, we have to look for the corneal endothelial function, and for systemic use, we have to get the baseline hepatic and the renal function. Now coming on to the cholinergic stimulators, the mechanism of action is that it decreases the IOP by stimulating the ciliary muscle contraction. The miosis induced by pilocarpine also improves the outflow in the eye with angle closure by pulling the iris away from the angle. So pilocarpine decreases the uveoscleral outflow and may cause paradoxical rise in intraocular pressure. Doses is usually QID with the maximum IOP lowering effect within 2 hours with a reduction in IOP of approximately 20%. Ocular side effects are the ciliary spasm, brow ache, miosis. Young patient with high accommodative ability may found to have more symptoms. It is relatively contraindicated in myopic patient because of the risk of retinal detachment. Cataract formation and corneal endothelial toxicity is also common. Systemic toxicity may include, although it is rare, but may include activation of parasympathetic nervous system in causing diaphoresis, lacrimation, salivation, GI distress and bronchospasm. If the patient is on myopic, we are not supposed to start the therapy. And if the patient have high accommodative ability, then also the drug is not indicated. Now the last class of the drug is the osmotic agent, mannitol and glycerol. These are very fast acting drugs, so used in emergency cases only. Mannitol minimizes the posterior pressure by changing the osmotic gradient between the blood and the ocular tissue. The onset of action is usually 10 to 60 minutes. Side effects are mainly CVS, overload, headache, nausea and confusion, and it is contraindicated in patients with cardiac and the renal issues because of the risk of overload. And glycerol, as we all know, that is contraindicated in diabetics. So the take home message is, if patient is ocular hypertensive patient, or we are suspecting high diurnal variation, then prostaglandin analog is the best drug for these patients. And if we do not have a baseline IOP, then it is not possible for us to assess the response to medical therapy. So whenever a patient comes to us first time, we need to establish the baseline IOP. That is very important. A post hoc analysis from advanced glaucoma intervention study proposed that if we lower the IOP below 18 millimeter on all visit, or an average of nearly 12.3 millimeter, would halt glaucoma progression. So it is like every patient is losing retinal ganglion cell on a daily basis, and thus the disease is always progressing day by day, but it is the rate of progression that is important. And undoubtedly this rate is generally lower in patient with low IOPs. We need to, before initiating any therapy, we need to balance between the risk and benefit of the therapeutic step. If patient is on prostaglandin analog and we want to add some other medication, then carbonic anhydrase inhibitors will be more beneficial. And to prevent the systemic absorption of drug, we may ask the patient to apply digital pressure over the sac area. Thank you.